a links worker, and I find that they're really useful for helping me to do social prescribing with patients, knowing what's on in the local area, finding out whether, a gardening group or anything that I can help direct patients to that are going to help them get out there, get involved, and maybe help their physical and their mental health. So I think at the moment the GPs don't have enough time to do a lot of social prescribing or concentrate on things rather than the medication. But I do think there is a shift towards that way of working. But I think crucial is for the health professionals and for patients to understand more about chronic pain and how to manage it without medication. And I think that's the kind of start of it.
And the best chronic pain clinics that I'm familiar with have got so many different people that work in them. They've got psychologists, they've got acupuncturists, they've got holistic therapies, they've had Reiki therapists. They've got OTs, they've got physios, they've got the whole plethora, haven't you? But that's very expensive in inverted commas. But ultimately, that's what's required, so that otherwise we just don't reach for the prescription. Remember Karen Sankey saying, look, it was just easier to prescribe the antidepressant because it was so difficult to access anything else that could help, even though you knew that writing the prescription probably was the wrong thing to do.
That's exactly it. I work with a lot of really good people. There's a physiotherapist in the practice. There's obviously the GPs, the nurses, the links workers. We're lucky enough in Glasgow to have a Live Active referral scheme, where it's an exercise referral scheme that we can refer patients to. So, and also because of the area I work in, Govanhill being like a really deprived area with a lot of people from minority ethnic backgrounds, there's a lot of third sector organisations in Govanhill that offer lots of support for patients. So I do spend a lot of time signposting patients to things that I think that would help them.
What you described as well is what they talk about in the NICE guidance. I know NICE guidance isn't, I'm not sure if it's extant in Scotland, but there was some controversy, wasn't there, around the NICE guidance, and it was talking about the sort of things that you two have just both talked about. But I can remember some pushback from some of the specialties on it. Is that right?
Yeah, I think there was some pushback. We have like sign guidance in Scotland, but I think we also use NICE as well. But yeah, there was a bit of controversy when it first came out.
But it was about the issue about primary chronic pain and secondary chronic pain. And the point is what I said before, which is that would be great. And we'd actually all love to be able to use non-therapeutic alternatives. But it requires all of those people that we've just described to be able to run it. Gosh, it's a while since we've mentioned the inverse care law, but you sound like you're working in an area, as you've just described, Tracy, that, there's lots of patients who need all of that support. I'm not saying any other people don't, but, there's the inverse care law in operation, isn't it?
Another area in Govanhill where we have problems with is a language barrier, because there's not a lot of access to a lot of these things in different languages. So that's one of the problems if you're trying to help a patient self-manage their pain, but there's no resources in the languages that they speak. It is easier just to reach for the pen and to write a prescription, and I feel they're not getting the same care as what English-speaking patients are getting.
How many languages did you say were in south of Glasgow?
I can't remember, but it's over 50 in Govanhill area.
So that's the number I've got written down when you said it, 50 languages spoken. Can you tell a listener your sugar mnemonic?
Yes, so this is basically the way that I kind of think about how I run my clinic. So it was like a spoonful of sugar helps the medicine go down, and I was thinking of it along the lines of medicine go down as in reducing medication. So S stands for social prescribing and also self-management, and U stands for both understanding the patient, so understanding what really matters to the patient, understanding how their pain's affecting their life, and also for the patient to understand what chronic pain is, so to educate the patients on chronic pain. The G stands for goal setting, working with patients to try and set up goals, just to kind of help them monitor their progress along the way and give them something to focus on. And A is for accepting that chronic pain is a lifelong condition, and it's a chronic medical condition, but at the same time that you don't need to look for answers for investigations or find out what's wrong with you. You can treat chronic pain as a condition in itself. And the R is for reviewing patients and also reducing the medication.
No further questions.
I absolutely love that. That's got to be turned into something, hasn't it? It's got to be turned into something. I mean, I suppose to finish off, but it follows on from that, you talked about doing some work around raising or improving the public knowledge and perception of pain. Is that just your patients, or are you looking at sort of wider community type focus?
We're actually setting up, myself and Laura Kenniser, who we're delighted to have actually said her name because she's a big fan of the podcast. She's a pharmacist who also runs pain clinics. Stephanie, who is a physiotherapist. The three of us are developing a online self-management and education programme, and we're going to pilot it in small groups of patients. And it's a 6-week kind of programme. One week we might concentrate on explaining all about chronic pain. The following week we might concentrate on like physical activity or improving sleep. So we're going to pilot that in the next few months, but we're also looking at doing some education with health professionals in Glasgow, like kind of joint working with the secondary care pain team, and also a GP who's a specialist in chronic pain management is going to come along and help to educate the other GPs and health professionals on winter funding for chronic pain. And one of the things that's came out is they've actually got Lorimer Mosley, who's like a well-renowned pain scientist, to come along through like a flipping pain webinar. So that's been like kind of sent out to all the practices in Scotland to let them know about it. So there's 3 flipping pain webinars coming up that the Scottish Government have funded, so that's quite exciting.
That's all brilliant stuff, and I think maybe we should put in the show notes the Flipping Pain and the Live Well with Pain resources for anybody that's not aware of them, because they are, I'm certainly aware with Live Well with Pain, which is excellent.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Fascinating stuff, and it's great to hear some insights from north of the border. Tracy, as you might know, one of the other pleasures of coming onto the Oral Apothecary as a guest is to offer us a few things. And the first thing is always a desert island drug, which is not to save you or your family on an island, but is something that evokes a powerful memory. So what would you like to offer us for that?
I don't know if you've had this one before, and it's not pain related at all, but insulin is my one because my daughter got diagnosed with diabetes a few years ago. And obviously it's a life-saving medication for her, but it's 100 years since insulin was first used in patients, and I just love the story about how the very first time it was used in patients, they injected it and the first patient went round the ward, and then by the time they got to the last patient, the first patient had already had a significant improvement. So that's my drug choice.
Brilliant. So I'm going to go out on a limb here, and I'm going to say, wasn't the inventor of insulin Scottish?
I was just thinking that. It was in Canada, wasn't it? But he was Scottish.
Yeah, it was in Canada, but I don't know if he was Scottish or not.
I think he was, because I used to have an expert patient come to talk to them about what it's like actually living with diabetes. So your daughter would be able to do such a session, and I'm sure you could equally do that. So yeah, it's a classic drug, isn't it? It is a lifesaver, but it's on that spectrum of, but you do need to be very careful with it, because too much is also, unfortunately, can be fatal. So in a therapeutic sense, it's a beautiful example of a medication.
We have had it before, haven't we?
We have, I think.
You?
Yeah, but that's fine. That's fine.
For very different reasons, if I remember rightly. Do you remember who it was?
I'm going to go Angela Carrington.
Yes.
From Northern Ireland.
Yes, I think it was too. So that's absolutely fine, because it's about something that's powerful and it evokes a memory to you. So as we said, insulin is a great drug. So we'll definitely take that. Thank you very much. And thank you for your daughter allowing us to talk about that. What about a career anthem then, Tracy?
This one actually relates to what we were talking about earlier on. It's quite a weird choice, but I was going to go for A Spoonful of Sugar Helps the Medicine Go Down.
That's great.
That's from a musical film, isn't it?
Yeah, it's from Mary Poppins.
Yeah.
Come on, Steve, from a musical film. One of the most famous films ever.
Never seen it, fortunately.
Is there a reason then, Tracy? Or just like the medical connection?
Because of what we were talking about earlier on, the spoonful of sugar helps medicine go down, but also because I like the story about why the song was made in the first place. It was because one of the songwriter's sons had came home after having his polio vaccine, and the father had said to the son, oh, how was it? Was it painful? And he said, oh no, because it was just put on a sugar cube and I swallowed it. And then they went and they wrote the song the next day. And I also like when you look into what the song actually means, and it talks about how if you make something more fun, or if a pleasant experience can help make the bad experience better. And I think that's what you do when you're self-managing pain or helping patients self-manage their pain. If they can make their life wider and have more going on in their life, then it helps their mood and then it helps their pain as well. So I thought it kind of links in quite well with that.
Oh, I love that. And I think I'm right in saying, and I'm not sure if it's a Welsh strategy or a UK-wide strategy, there was a pharmacy strategy about 20 years ago called A Spoonful of Sugar. And a lot of the stuff that we see today was first mooted in there, sort of independent, supplementary prescribing. I think they were probably talking about the wild idea that pharmacists would work with GPs. It was all in there, I think, Spoonful of Sugar.
Yep, it certainly was.
What was that? Was that Audit Commission or was it a national
Yes,
strategy?
I think it was the Audit Commission before it turned into the CQC, Care Quality Commission. Very good. Well, we'll definitely take that. Who doesn't like Mary Poppins? And as we always say, there is actually a Oral Apothecary Spotify playlist, and so we always update that every time we have a new episode. So Tracy's song will go into that. And the final thing we're after is a book recommendation for the listener to go into the Oral Apothecary Library. So what did you make of this?
The book that I would like to recommend is Explain Pain, and that's actually written by Lorimer Mosley, who I mentioned earlier on, and also David Butler. So it's written with like a kind of pain science background, and it really explains all about how pain works in the body, and it gives lots of really good examples of different experiments and things that have been used to kind of explain how pain works. And it can be used along with patients, or you can just read it. It's good for health professionals and patients alike.
Excellent. Okay, so Explain Pain by Lorimer Mosley and David Butler.
That's it.
Right, excellent. Well, I hope you had fun thinking about those three things. I know sometimes the guests say they do like that part of it, even though you have to think. So great choices as ever. I think it's me again on the micro discussion, and we thought, seeing as Tracy was on, we should talk about something that was relevant. So this is a paper that's by a large group of authors, but Sue Wood is the lead author, from the Leeds Institute of Health Sciences. This was taken from the British Journal of General Practice in October 2021, and it's about general practice responses to opioid prescribing feedback. It's actually a qualitative study, so they interviewed people who worked in practices, whether they were GPs, pharmacists, practice managers, around a scheme that was running in Yorkshire, which was allowed an evidence-based bi-monthly feedback intervention to try and help reduce opioid prescribing. And that happened for 316 practices in West Yorkshire over 1 year. And so what the study was trying to do was trying to find out, using something called normalization process theory, which brought me out in a cold sweat, having done qualitative work, trying to find out and understand how the staff received and responded to the feedback intervention and what came of that and their views of it. Who'd like to kick us off? Tracy?
Before you start, Tracy, if there's any patients or people listening to this now, can you just tell us what opioids are we talking about out there in practice?
From the kind of less strong ones like cocodamol, dihydrocodeine, tramadol, up to like your morphines, your oxycodones, your fentanyl.
Thanks, because we talk about opioids all the way through, and I just thought let's mention a few drug names here for people.
Okay, and also maybe then just before Tracy kicks off, for the non-health professional listener, you have to remember that this stat passed just last year, where the US, for example, had 100,000 drug overdose deaths in 2020 due to opiates. And actually, in the last 20 years in America, there has been 1 million, I repeat, 1 million drug overdose deaths due to opiates.
So I had a look at the paper, and it was really interesting to see how the bi-monthly feedback motivated the GPs to continue working on opioids. But the bit I liked about it was when one of the GPs got quite excited about the patient feedback. The patient said, "Gosh, I'm a changed person, I can focus on things." I want to do stuff. I've got that enthusiasm. Otherwise, I was just a blank person. And I thought it was quite good how the conversations about opioids every couple of months, the GPs talking about what patients were saying and the feedback they were getting kind of motivates them to continue with the work.
Thanks, Tracy. I'll just add to that is friends, colleagues, they ask me, well, why don't you just change things then? Why don't you just stop people doing things that you don't want them to do? And so I said, well, that's, behavioural change isn't like that, is it? And so this, for me, I've read it a couple of times after Steve sent through on the WhatsApp group to say, need to read it a few times to get the most out of it. But it just shows you the level of detail that we need in addressing some of these behavioural change, so it's not as simple as saying, don't do this or